Hi everyone, good morning. Welcome to the GlowDerm webinar series. Today we'll be having a lecture on dermatopathology presented by the great Dr. Amani Uwajeni Alice. Um, just a few housekeeping slides before we get started. Your hosts today are me, Akash Varma. I'm the chair of the GlowDerm Training Committee. We have Dr. Doreen Mapunda and Dr. Musna Masood and Dr. Jamila Garib. So just, to remind you guys that we are the GlowDerm Trainee Committee. We're part of the International Alliance for Global Health Dermatology, known as GlowDerm, which is also a subsidiary of the International Foundation of Dermatology. And our goal is to promote knowledge equity by improving access to education for dermatology trainees across the world. We aim to provide free educational events and opportunities to build networks and to collaborate. So just a little bit of meeting etiquette. Your audio will be muted and your camera will be turned off for the duration of this webinar. But if you do have any questions or comments, you can submit them via the chat function or the Q&A button. It's your choice. And our additional meeting hosts will share these with the speakers to answer at the end of the webinar. And we'll also be sharing some further information about our training committee in the chat function, so please be on the lookout for those messages if you can. So without further ado, I'd like to present our webinar. Becca, if you could share the slides.
Hello. Good afternoon, and good morning and good evening, depending on where you are. I'm Dr. Alice Amani, a dermatologist in Rwanda. I'm pleased to share with you the cases we are reviewing during our daily practice. I have no conflict of interest. Our outline is lichenoid dermatitis will be discussed, granulomatous disease, blistering disease, psoriasiform dermatosis, as well as skin tumors. Our first patient was a 38-year-old female patient who consulted for hyperpigmented violaceous papular lesions on the trunk. Here we show the back. On the abdomen, the entire body was affected, but the nails were not affected. We had differential diagnosis, and the number one was lichen planus. Of course, psoriasis was not excluded. And then we took a biopsy, which showed compact hyperkeratosis, focal hypergranulosis, a bit of acanthosis, and a band-like infiltrate. We can see it not easily some apoptotic keratinocytes were also seen in the epidermis. With this, we concluded the case as lichen planus classical type, which has been managed with topical steroids, intralesional triamcinolone, and currently the patient is doing well. Our next case is a female of 41-year-old who presented for hyperpigmented patches in the ear, on the face, as well as on the other part of her body, including a scarring alopecia. The age of the lesion was having hyperpigmentation, but it was a complete alopecia, scarring alopecia, as you could see here. With this case, we had different differential diagnosis, among which lupus was involved. And then we took some workup tests, but involving biopsy punch. The biopsy punch done revealed a compact hyperkeratosis, some follicular plugging, superficial perivascular infiltrate, plus periadnexa. On the higher magnification, as we are going to see in the next slide, we see evidently that we have vacuolar degeneration at the basement of the basement membrane, but here also perivascular infiltrate, as well as periadnexa. we couldn't visualize a thickening of basement membrane, and we ordered PAS staining of the case, which revealed the thickening of the basement membrane. And then with the previous case, a discoid lupus erythematosus was confirmed, managed accordingly with hydroxychloroquine and topical steroid plus sunscreen. Our third case is a female patient who presented with edema of the face. Rash were also affecting the V-neck. The arm where proximal muscle of the arm were so weak, and this periorbital edema and perioral edema was also visualized. Another different case presented with the same picture, but classically with this chalky-like nodular lesions on the extensor. This was a juvenile of 13 years. Similar condition in a different patient of 69 years old with infiltration and dilation of the upper part of the trunk. Arm were difficultly to be mobilized. As you can see, the proximal muscle looks like atrophied. The thighs were also affected with induration and some carcinosis cases. On the hands, dorsal hands, we could see some rash on the wrists and as well as on the hands. And these were the Mutron papilla. A biopsy was taken plus antibodies, but we are going to share with you the biopsy, which showed atrophy of epidermis with almost complete flattening of red lesions and sparse perivascular infiltrate. On the higher magnification, you can see a focal parakeratosis, flattening of epidermis plus focal vacuolar degeneration and perivascular infiltrate made of lymphocytes. Difficultly, we couldn't see any other thing like thickening of basement membrane. So in this, we concluded as the case as dermatomyositis of an adult. With the case of carcinosis cutis, it was a juvenile dermatomyositis, which were both managed quite well, and the patient are now doing well. Our next case is a 10-year-old male patient who was using Coartem, which is anti-malaria sulfur. He developed almost all the time he was taking the medicine, he could develop this hyperpigmented when demarcated patch. Another case in a female patient, 16, who also was taking Brufen for dysmenorrhea, and she was getting the similar lesion, always taking the Brufen. So we had an impression of fixed drug eruption. We did a biopsy, which shows here on lower magnification, superficial and deep inflammation with some melanin pigments. We see it better on higher magnification. Unfortunately, it was not shared. So this was concluded as fixed drug eruption, first to the Coartem, which is a sulfur, but also the Brufen. So patient was educated to stop using this kind of medication and improved. The another case is a 13-year-old female patient who was having kidney failure, and for that managed with beta blockers. And this was taken for almost 3 months, but suddenly 5 days prior to the consultation, she presented generalized body skin necrosis with some peeling, complete denudation of the skin. And these were unveiled also the mucous membrane, oral and genital, as well as the face, the eye, sorry. A biopsy was taken, showing up the acute of the face. We can see that we have just orthokeratosis basket web and complete full thickness necrosis in the epidermis, plus a subepidermal cleft. So a fixed drug eruption was, toxic epidermal necrolysis was concluded in this patient. Unfortunately, she died with the kidney failure. The next case is a 68-year-old female who consulted for multiple patches, plaque on her trunk, of which differentials could be psoriasis or mycosis fungoides or parapsoriasis. A biopsy was taken, And it showed basket wave orthokeratosis, parakeratosis, and inflammatory cells, which is cell-rich with lymphocytes with involvement of epidermis. We did a process of CD4, CD8, and this is CD4 positivity, showing that there is epidermotropism in the epidermis. And the mycosis fungoides was confirmed. Patient was plaque stage, was managed with steroids and PUVA therapy. She's currently well. And next patient is a 69-year-old female patient who presented for 4 years history of skin induration, infiltration of left lower leg from the mid thigh till to the ankle. So here we had an impression, could it be linear scleroderma, morphea, and the biopsy taken showed a squared shaped punch biopsy with almost atrophy of epidermis and almost homogenization of the dermis. On the higher magnification, we can difficultly see adnexa or blood vessels, difficultly really. And with this, some atrophy of the epidermis. So the previous was concluded as linear scleroderma managed. Currently, the patient is doing well. The next is a female who also consulted for well-demarcated hypopigmented patch on the lower abdomen, as well as groin, pubis. And here you can see there is also involvement of the vulva and labia minora. This is just yesterday when we saw this patient. And guess what? The histology shows homogenization of the papillary dermis, pushing down the inflammatory cell, pushing down again the inflammatory cell. Here it's completely like a scar lesion. So a diagnosis of lichen sclerosis atrophicaus was confirmed. As you saw in the previous picture, this is the patient after 6 months on clobetasol. There is really a great improvement in this patient. The next is a male of 32 who consulted for silvery, scaly plaque on the all over the body, but here it's just the back. We took a biopsy, and in this one, we can easily see a regular acanthosis with some thinning of suprapapillary epidermis, sorry. And here, a classical parakeratosis is visualized, atrophy or thinning of suprapapillary epidermis plates, which made us confirming a psoriasis, and methotrexate topical steroid Ivonex were initiated. The patient is doing well. The next is an elderly 71-year-old who consulted for vesicles all over her body, sparing mucous membrane, some vesicle here, as well as on the thigh with erosion and excoriation, and vesicles and bullae. For this one, as an elderly epidemiologically, BP was considered, bullous pemphigoid, biopsy taken showed subepidermal blister and cleft with eosinophil infiltrate. So a bullous pemphigoid was confirmed based on the morphology. We didn't do immunofluorescence because we don't have it. Now again, a boy of 14 years with vesicle and bulla on the thighs. Here, the mucous membrane were affected. A biopsy just showed suprabasal cleft in this section. Here we have a classical tombstone, which made us confirming pemphigus vulgaris in a 14-year-old male patient. And it has been managed accordingly. Here we are sharing now a boy who is 13, who consulted for multiple vesicles all over the body. He was weak, associated with fever, and we had, could it be chicken pox, monkeypox? And then we took a biopsy, which also revealed basket wave orthokeratosis and a vesicles in the intraepidermal vesicles. On high magnification, as you could see, there are those keratinocytes tend to be balloon cell. This is classical for herpetic infection, zoster, chicken pox, and as well as herpes simplex chronicus or herpes simplex, sorry. And then in this case, we concluded the chickenpox, patient managed and doing well. The next is a 1-year-old male who had well-demarcated annular ring-like lesions on the thigh. Granuloma annulare was one of differential. Fortunately, the biopsy confirmed it by revealing a collagenolysis surrounded by inflammation. In this case, granuloma annulare was confirmed as a differential. Patient used topical steroid and improving. The next is a 71-year-old male patient who had multiple well-demarcated scaly plaque all over the trunk, arm, thighs. In this case, we have naked granuloma all over the dermis, and sarcoidosis have been confirmed, managed accordingly. The next is a female 35-year-old who presented well-demarcated fixed nodular lesion on the upper lip, of which a biopsy taken revealed a dermal lesion characterized by epithelioid tumor. On the higher magnification, we can see it better, but here we have a chondroid differentiation, epidermoid tumor. In this vision, you cannot see the mucin, but this was concluded as chondroid syringoma or mixed tumor and managed with biopsy. The patient is managed with excision. The patient is doing quite well. And next is a 4-year-old patient who presented a yellowish plaque, tumor-like lesion on the scalp. The same patient now in a different time, a different patient who now came in 1 year, in 1 week after birth with this yellowish plaque on the scalp. And on the histology of this case, we found just sebaceous glands in the epidermis, which is named as sebaceous nevus of Jadasson, which was concluded. The patient was educated on the possible good outcome, and nothing was done at this stage, but we advised to monitor later because there are possibilities to have basal cell, trichoblastoma, and so on. And next is a female patient who had 4-year history of this hyperpigmented dark plaque, which were somehow scaly on the left breast. The right one was spared. So we had possible Paget disease, mammary Paget disease, a biopsy taken here showing some cell differentiation in the epidermis, which are not the usual one of epidermis. On the higher magnification, you can see this differentiation of the cells and looking like apocrine glands in the epidermis. And for this one, Paget disease was confirmed. Patient transferred for the proper management for the breast specialist, to the breast specialist. And next is a 20-year-old female patient who presented this boggy-like mass on the, this is the vulva, sorry, the labia majora. So it was covering always the, almost the entire labia majora. A halfway could be seen. And the patient, as a 20-year-old complex with such a lesion, the family was somehow depressed. By excision biopsy taken showed full thickness dermal differentiation of mature adipocyte, which made us concluding as nevus lipomatosis, and excision done, patient now doing very well. The other patient is a 56-year-old male who presented this well-demarcated ulcerated tumor lesion on the heel since the previous 5 years. Biopsy taken could show that there is erosion and melanocytic lesions in the epidermis, or pagetoid spreading of them. With this, we concluded acrolentiginous melanoma and advised surgical review and management for further. For this stage, I have to highlight that no lymph nodes were affected. This, at the higher magnification, you still see some melanophages all over the epidermis, but also in the dermis. I couldn't share more picture, but this is really classical acrolantiginous melanoma. The other patient is this one who also presented the firm tumor lesion on the lower back. This tumor lesion has been there for the previous 5 years, and the patient was thinking maybe it is post-trauma. She thought of a lot of thought around it, and we took a biopsy, which showed normal epidermis, and almost the lesion was only in the level of the dermis. The next part of it, that the lesion could also invade the fat. A Combe-Stone pattern was confirmed here, and we ordered CD34, which was positive, and we confirmed dermatofibrosarcoma protuberans. We did a complete excision of the lesion. The patient is now doing very well. Thank you very much for your attention. I kindly thank my mentor, Dr. Helmut, who taught me dermatopathology. I thank all and you for your continuous support. Enjoy the rest of your day. Thank you. I welcome now question, comments.
Thank you, Dr. Alice, for that very insightful presentation. So far, I'm not seeing any questions on the chat or on the question and answers. Please feel free to ask her any question on this presentation or anything about dermatopathology. You can write them on the chat or in the Q&A section.
Sure.
So one of the questions,
yes,
someone is saying, I didn't get the diagnosis of the boggy lesion on the vulva of the young girl. So may you please repeat that?
Nevus lipomatosis.
Thank you. Another
welcome.
question from Joseph. Thanks, Doc. My question is on the bullous pemphigoid. In settings where we don't have immunofluorescence, how can we differentiate it from 10?
From 10?
Yes.
Yes. Thank you very much. Bullous pemphigoid present as a subepidermal blister, but it has inflammation and no necrosis. For 10, you get necrosis, full thickness necrosis of the epidermis. Usually in bullous pemphigoid, they shouldn't be necrosis or apoptotic cell, no. You just have a blister, which is at the level of subepidermis, and then you get also inflammatory cell, including eosinophil, lymphocytes, while 10 is a cell-poor inflammatory condition. So usually you don't find inflammatory cell. And if you find, you don't find eosinophil. So the pattern of level of the cleft can be the same, but the pattern of inflammation is completely different. Eosinophil in BP, also intravesicular vesicle, eosinophil can be there. No necrosis in BP, while in 10, there will be necrosis of the full thickness epidermis. That's why our patient was also having denudation. The skin were necrotic. In bullous, you see vesicle, bulla, but no necrosis, clinically as well as histopathologically. Thank you.
Thank you very much. I think that was very clear. We have 2 questions so far in the chat. One wants to know, for the patient with discoid lupus, where do you advise to take the punch biopsy?
This patient was having the lesions all over the body, but of course it's better to get it at the edge. Don't take it in the atrophy, but when you have erythematous patch, that's the site which is better. But for this patient, I just showed the head, but the lesion were all over. It's better to take, if you really want histopathology, it's better to take where is the active lesion. And then you can take on the scalp only to confirm, is it a scarring alopecia? And that we have to highlight that you need 2 types of biopsy, which should be grossed differently, one in vertical section and one in horizontal section. With both sections, you have chances to say this is complete scarring alopecia or something else. So you can at least advise the patient about the outcome of the alopecia.
Thank you.
Mm.
There's also another question, not about the presentation, but someone says thank you very much for the wonderful presentation. I was hoping you could share some of the earlier trainees, what inspired you to specialize in dermatopathology?
Okay. First of all, dermatopathology brings solution where you are confused. It opens mind when you are really confused. Like for the case we presented of lichen sclerosis etatropicans, even though it was nicely well demarcated to be vitiligo, at least there was a possibility with the biopsy to have a clear final diagnosis. So somehow dermatopathology makes someone becoming more and comfortable dermatologist. You work independently. And in the setup of Africa, where we don't have any dermatopathologists, and usually pathologists being interested with non-inflammatory skin diseases, mainly tumors, they don't usually help us. So being a dermatopathologist was like a spice to be a dermatologist. So you work confidently and more comfortably and more independently. So those were the main reason, but of course, having good mentors who also took my hand for many years. Helmut was someone who inspired me again to be dermatopathologist and opened the door. Another thing, during my residence, we didn't have a technician in the laboratory. These technicians who were not there, and we had the pathologists, we residents, we were rotating in the laboratory to process the sample, do everything which a technician should do. And this I did for the first year, but I was never able to read the slide. Then I said, why should I cook the food which I'm not going to eat? So definitely I said I should focus in dermatopathology, because if I can be a good technician, I can also read well the slide. So those were the doors which were opened to me and opened the mind, and I was lucky to find the door open of the specialization. Thank you.
Thank you for that. So let me just follow up that question. Someone else wants to know where you did this specialization in dermatopathology. Someone is interested to pursue it and wants to know where you did it. Yeah.
Yes. The Europe has the program and USA has the program. I had the chance to do my dermatopathology training in Switzerland, Bern, in Salzburg Hospital via the grant which Helmut was following. This is someone you probably know or you have met or you will meet, who initiated the development of dermatopathology in Africa. And most of the dermatopathologists we are having passed through his mentorship, and we all had the chance to meet him and be sponsored by him by the grant he had during that time. So in Switzerland, there is this opportunity. In Austria, through Ceroni, who is a specialist in lymphoma, he has also the training, and this is hosted by International Society of Dermatopathology. So usually there is also a website where you can apply. It's not always open, but you have to keep knocking at the door. Keep knocking at the door, and usually on the website of African Dermatopathology Society, when there are such opportunity, it is shared to colleagues. Yeah.
Thank you very much. There's one last question in the chat. Thank you so much, Doctor, for the good presentation. How can we tell congenital melanocytic nevus from the kid who has nevus lipomatosis? How can we differentiate that?
Okay. Melanocytic nevus, it's ectopy of melanocyte. So you can understand that nevus usually has a synonymous of ectopy. Anything on a different place, it is called nevus in the dermatology. So you heard me saying nervus sebaceous. Those were sebaceous glands in the epidermis. Now, nervus lipomatosis, they are lobules and fat lobules where they are not supposed to be. They are now in the dermis. That's why they are called nervus lipomatosis. So melanocytic, now you have melanocytic cell, not fat. So melanocyte is different from the fat. So melanocyte, they are usually found in the basement membrane of the epidermis. Then if you find it in the dermis, they are not in their place. That's when they are called nervus, melanocytic nervus, dermomelanocytic nervus, and so on. I hope it's clear.
Thank you. So far, I'm not seeing any more questions. But thank you very much for those responses.
Thank you. You're welcome.
Yes, thank you so much. I think that concludes our webinar for today. Thank you so much for an insightful talk and for answering everybody's questions. And we thank all the participants for being so actively engaged. We hope you guys learned something today, and feel free to follow us on social media to learn more about upcoming events, webinars, programs. And yeah, have a great rest of your day or night, wherever you're located. Bye, everyone.
Bye-bye. Thank you.